Hi everybody, and welcome to our module on lipid drugs. Before we talk about lipid-lowering drugs, let's talk about how you assess the lipid status of a patient in the clinical setting. When you're on your clinical rotations, you will see many patients go for blood testing to assess what's called the cholesterol panel or the lipid panel. And this is a set of 4 measurements used to determine the patient's lipid status. The 4 measurements are the total cholesterol level in the plasma, the LDL-C, which is the cholesterol associated with LDL particles in the plasma. We usually don't directly measure the LDL particle level. Instead, we measure the level of cholesterol associated with LDL, and that's called the LDL-C. We also measure the HDL-C, which is the level of cholesterol associated with HDL. And then finally, we measure the total plasma triglyceride levels. And you may know that there are many other lipid particles like chylomicrons and VLDL and IDL, but these are not routinely measured. These are the 4 things that are routinely measured in patients. And it's difficult to actually measure the LDL-C directly, so it's usually calculated through something called the Friedewald formula. And the Friedewald formula says that the LDL is equal to the total cholesterol minus HDL minus triglycerides over 5. And as long as the triglyceride level is not too high, this is usually accurate. So this is usually the way LDL is determined, and then we directly measure total cholesterol, HDL-C, and the triglyceride level. When you get back the results of the lipid panel in one of your patients, you need to be able to interpret them. And remember that in general, hyperlipidemia is usually a silent killer. It usually doesn't cause any symptoms unless the lipid levels are very, very high. So what you're trying to determine from the lipid panel is the patient's risk, and you want to treat them with drugs if their risk is too high. So the first thing you want to look at is the LDL cholesterol. This is referred to as the bad cholesterol. Some people remember the L is for lousy or bad. And the reason this is called bad cholesterol is because LDL cholesterol is associated with increased risk of cardiovascular disease like strokes and heart attacks. A level under 100 milligrams per deciliter is considered very good. A level over 200 is considered high. And there's very, very good clinical evidence that if you treat high levels of LDL for most patients, you reduce their risk. Remember, when you give a drug that lowers the cholesterol, you don't know if you have also lowered their risk of having a heart attack unless you do a clinical trial. And in the case of LDL cholesterol, we have lots of clinical trials that say that it's worthwhile to treat high levels of LDL cholesterol in most cases. HDL cholesterol, on the other hand, is called the good cholesterol. A lot of people remember the H is for healthy. And the reason it's called good cholesterol is because the higher the HDL level, the less the risk of cardiovascular disease. It's inversely associated with risk. We consider a level below 45 to be low, and anything higher than 45 is good. And an important distinction here compared to LDL is that we have very little evidence that raising low levels with drugs reduces risk. So there are some drugs that we'll talk about in this module that can raise the HDL level. Unfortunately, the clinical trials that evaluated patients who took those drugs showed not much change in their risk of developing cardiovascular disease. Therefore, it's very uncommon to see us treat someone with a low HDL level. On the other hand, we very often treat people who have high LDL levels. Triglycerides are another component of the lipid panel. A normal triglyceride level is under 150 milligrams per deciliter. And one important thing to know about triglycerides is that if the level gets very high, such as over 1,000, this can cause pancreatitis. We'll talk more about this on the next slide. But the important thing to know is one of the reasons we often treat very high triglyceride levels is not to avoid coronary disease or strokes, but to avoid pancreatitis. Elevated triglyceride levels have been shown to be modestly associated with an increased risk of coronary disease. However, much like HDL, there's very little clinical trial evidence that says that if you treat someone with high triglycerides with a drug to lower their levels, you will reduce their risk. So it's very rare to see high triglyceride levels treated solely to reduce the risk of coronary or vascular disease. As I said before, though, you do often treat very high levels to avoid pancreatitis. So markedly elevated levels of triglycerides can cause acute pancreatitis. Why does this occur? Well, the exact mechanism is not known, but it's believed that it may involve chylomicrons in the plasma. Recall that chylomicrons are very large particles and are usually formed after meals, and then they clear a few hours later as your body metabolizes all the triglycerides inside the chylomicrons. However, when your triglyceride level is over 1,000, chylomicrons are always present, and they're large particles, and it's believed that they may obstruct capillaries in the pancreas, causing ischemia. When the vessels become damaged, the triglycerides in the chylomicrons are exposed to pancreatic enzymes like lipases. This can break down the triglycerides and release free fatty acids. This can cause local acidosis in the tissues and lead to tissue injury, and this may be the mechanism of pancreatitis. But whatever the mechanism, you should know that when the triglycerides get very high, acute pancreatitis can result. Let's talk about when you would treat hyperlipidemia. When you're on clinical rotations and you see patients taking drugs for elevated cholesterol levels, most of them are being treated for elevated LDL-C levels, and most of them are going to be treated with the statin drugs, which we'll talk about later in this module. It's very rare that you'll see patients treated for elevated triglyceride levels or low HDL-C levels, because as I told you before, the clinical trial evidence that treating these lipid abnormalities is beneficial to the patient is relatively weak compared with the data supporting LDL treatment. The best data for treating hyperlipidemia comes for secondary prevention. Secondary prevention is preventing disease among patients who already have established disease. So secondary prevention in hyperlipidemia is treating high lipid levels in patients who already have coronary or vascular disease. For example, a patient that's already had a myocardial infarction. In these patients, there's very strong clinical trial evidence that treating high levels of LDL cholesterol with lipid-lowering drugs, usually statins, provides a benefit in terms of lower risk of cardiovascular events. Primary prevention is the treatment of hyperlipidemia in patients who haven't had a coronary or vascular event yet. In this case, the data are less strong for treating hyperlipidemia, and that's because not all patients benefit the same. The greatest benefit occurs when you treat patients who are at very high risk of cardiovascular disease. So in other words, the benefit depends on the risk of cardiovascular disease. There are some guidelines that you can use to determine when to treat patients with hyperlipidemia. There are some older guidelines that I learned in med school that are still used by many clinicians that advise you to treat based on a goal LDL cholesterol. These guidelines say that for patients with diabetes or established coronary disease, the goal LDL cholesterol is under 100. So if the level is higher than 100, you administer a drug, usually a statin. If the patient does not have diabetes or coronary disease, but they have 2 or more risk factors, the goal rises to 130, and you only treat if the LDL cholesterol is above 130. And then finally, for patients with 0 or 1 risk factor, the goal is 160, and only if the LDL cholesterol is above 160 do you treat, usually with a statin. There are some newer guidelines that are somewhat controversial. Many clinicians don't like them, that require a risk calculator. These guidelines do not use the LDL cholesterol. They tell you to treat all patients if their risk of cardiovascular disease is too high, usually above 5% a year. So you simply calculate the patient's risk of cardiovascular disease, and if it's high, you administer a drug, usually a statin, and there is no LDL goal. And as I've been alluding to in what I'm saying on this slide, statins are the first-line therapy for the majority of hyperlipidemia patients, and that's because they're very effective at lowering the bad cholesterol, the LDL cholesterol, and they have the best evidence that they also reduce the risk of coronary and vascular disease. As I said before, we usually treat high LDL levels. It's very uncommon to treat a high triglyceride level or a low HDL level. One of the reasons for this is that many LDL drugs, especially the statin drugs, improve triglyceride and HDL levels. So if you just focus on the LDL level, you often improve the levels of these other lipid particles as well. And then in addition, as I said before, there are very few clinical trial data showing a benefit of treating high triglyceride levels or low HDL levels. On this slide, I've shown a couple of situations where you may sometimes see triglycerides or HDL levels treated. When the triglycerides are over 500, some clinicians will treat this. This is not only to reduce the risk of cardiovascular disease, but also to avoid pancreatitis. And then some clinicians measure what's called the non-HDL cholesterol. This is the total cholesterol minus the HDL. And if this level is higher than accepted norms, sometimes triglyceride levels are treated. For low HDL, you will very rarely see this treated, but some clinicians will administer drugs to raise the HDL level in patients who have established coronary disease. For example, a patient who's had multiple heart attacks with a low HDL level, you will sometimes give a drug to raise the HDL in the hopes of avoiding subsequent coronary vascular events. For the remainder of this module, I'm going to talk about specific lipid-lowering drugs. I'll talk about all these items listed on the screen here. And then finally, before I get into any of the drugs, I should mention that diet, exercise, and weight loss are a great way to reduce cholesterol and lower cardiovascular risk. I don't know if you'll be asked this on step 1, but you certainly should be aware that patients who get more exercise and lose weight will have improvement in their lipid panel. And in fact, I've had a number of patients who are on drugs for high cholesterol be able to go off those drugs after they lost a significant amount of weight and change their diet and exercise habits. The first class of drugs we'll discuss are the statins. These are drugs like lovastatin, atorvastatin, simvastatin. They all end in the word statin. These drugs act on the liver and they inhibit the synthesis of cholesterol by the liver. And the way they do this is by inhibiting the enzyme HMG-CoA reductase. HMG stands for 3-hydroxy-3-methylglutaril coenzyme A, or HMG-CoA, and the enzyme HMG-CoA reductase converts this very large molecule into a molecule of mevalonate. If you look carefully at the structure, you'll see that everything from this sulfur molecule in this direction is the substance coenzyme A. Everything from the sulfur molecule this way is the substance mevalonate. So basically HMG-CoA reductase splits off coenzyme A, leaving the molecule of mevalonate, and then mevalonate is used to synthesize cholesterol by the liver. So when you inhibit this enzyme, you inhibit the synthesis of mevalonate, and therefore you decrease cholesterol synthesis in the liver. Now, the board examiners who write the questions for step 1 are well aware that many students memorize that statins inhibit HMG-CoA reductase, so they're unlikely to ask you about this enzyme. What they are more likely to ask you about is the fact that the result of treating patients with statin is to increase LDL receptors in the liver. Because the liver can't synthesize its own cholesterol from mevalonate, it will add LDL receptors to the surface of cells to try to pull in LDL molecules and get cholesterol from those lipid particles. This increase in LDL receptors on the surface of liver cells is what lowers the LDL levels in the plasma, and therefore the major effect of these drugs is to decrease LDL levels. There's also some decrease in triglyceride levels and some increase in HDL levels. And the best thing about statins when it comes to treating patients is that there is very excellent outcomes data showing that treatment with these drugs lowers the rate of myocardial infarction and death from cardiovascular causes. An important side effect to know of these drugs is that they can raise the liver function test, and this is easy to remember because HMG-CoA is found in the liver. HMG-CoA reductase is also found in the liver, so therefore it's fairly straightforward to remember that it's possible for these drugs to cause an elevation of liver function enzymes. Besides elevated LFTs, the other side effect many patients have when they take statins is muscle problems. There are many different muscle symptoms that have been associated with these drugs. The exact mechanism is poorly understood, but it has been established that many patients who have muscle aches on statins have low levels of coenzyme Q found in their muscles. Recall that coenzyme Q is part of the electron transport chain. For this reason, many patients take supplements called CoQ10 to try and increase the level of coenzyme Q in their muscles and potentially relieve the muscle aches. This is theoretically beneficial, but there are no clinical trials showing that CoQ10 works to relieve the muscle aches. So let's talk about those muscle problems that patients can get on statins. The most common problem is called myalgias. These are patients who experience weakness or soreness in their muscles when they take statins, and if you measure the level of creatine kinase looking for evidence of muscle damage, the level will be normal. Less common than myalgias is to develop myositis. This is like myalgias in that patients have weakness and soreness of their muscles, but in this case the creatine kinase level is elevated in the plasma. And then the most dangerous side effect of statin drugs, which is luckily very rare, is rhabdomyolysis. This is weakness, muscle pain, and dark urine. The dark urine comes from creatine kinase and myoglobin spilling into the urine. The CKs will be in the thousands. These patients can develop acute renal failure and even death. And the rate of this complication is very low on statins by themselves, but the risk is increased if you take statins concomitantly with other drugs. Two well-known culprits are cyclosporin and gemfibrozil. Gemfibrozil is a fibrate, and we'll talk about this in a minute, but if you take it together with the statin drug, there's an increased risk of rhabdomyolysis. Some statins are more hydrophilic and some are more lipophilic. The hydrophilic statins are pravastatin and fluvastatin and rosuvastatin, and there's some evidence that the hydrophilic statins may cause less myalgias. The lipophilic statins are atorvastatin and simvastatin and lovastatin. They may cause slightly more myalgias. Atorvastatin and simvastatin are very popular and they're generic and they're very cheap for patients, so many clinicians will prescribe these drugs. However, if the patient develops side effects such as myalgias, many clinicians will switch to rosuvastatin, which also goes by the name Crestor. It's a very potent statin and you can put patients on a very low dose and it will often lower the LDL, and sometimes there's less myalgias on that drug. Statins are metabolized by the liver P450 enzyme system, so there are interactions with many other drugs. Inhibitors of the P450 system in particular can increase the risk of abnormal liver function tests and myalgias. One that your patients will often ask you about is grapefruit juice. Grapefruit juice is a weak inhibitor of the P450 enzyme system, and every once in a while patients will read something in the paper saying not to take grapefruit juice. The reality is if you drink an occasional glass of grapefruit juice, you'll probably be fine, but if you drink a lot of it, it may cause increased side effects if you're also on a statin drug. The next lipid-lowering drug we'll discuss is niacin. Niacin, you may know, is vitamin B3, and I discuss it in more detail in the modules on B vitamins, but for our purposes here, we're going to focus on its lipid-lowering effects. Its mechanism of action is complex and it's incompletely understood. Overall, what it does is lower LDL to a modest degree and raise HDL to a modest degree, and in fact, its main use is in patients who have a very low level of HDO that you want to increase in order to hopefully reduce their risk of cardiovascular events. If you read the literature, you'll find lots of studies describing different effects of niacin that lead to changes in lipid levels. Some that are worth knowing are decreased rates of fatty acid mobilization from adipocytes, which can lower triglyceride levels. There's less VLDL synthesis by liver cells when patients are receiving niacin, and as you know, VLDL gets converted into LDL, so this will lead to lower LDL levels. And then finally, niacin has been shown to decrease the rate of HDL breakdown, and this may be some of the mechanism by which HDL levels climb in patients who take niacin. The most important side effect of this drug is flushing. It stimulates the release of prostaglandins in the skin and the face turns red and warm. And if you ever prescribe this for a patient, you'll find that many of them don't like it. If they take it in the morning and go to work, everyone at work will remark that their face is bright red. Sometimes their face can feel like it's burning. You can blunt this side effect by administering aspirin prior to niacin because aspirin will inhibit the prostaglandin release, although there sometimes still is a degree of flushing. This will fade over time, but unfortunately many patients discontinue their niacin because during the first few days and weeks they're taking it, this flushing is very bothersome. Two other side effects of niacin to be aware of are that it can cause hyperglycemia. It's been shown to result in some level of insulin resistance. The mechanism is incompletely understood. Niacin is a drug we try to avoid in diabetics, and then it can also increase the uric acid level. So patients who are vulnerable to gout attacks, like this patient in the picture here, should avoid niacin because it may precipitate gouty arthritis. The next class of lipid-lowering drugs are the fibrates, and all the drugs in this class have the word fib somewhere in their name. So this includes drugs like gemfibrozil, clofibrate, bezafibrate, and fenofibrate. The way these drugs work is they activate structures called PPARs. PPARs are peroxisome proliferation activated receptors, and fibrates activate PPAR alpha. You may know that there is a diabetes drug called pioglitazone that works on PPAR gamma. When fibrates activate PPAR alpha, they modify gene transcription, and this leads to a number of changes in enzymes and metabolism of fatty acids. One of the most important changes is that there's increased activity of lipoprotein lipase. In addition, there's increased fatty acid oxidation in the liver, which lowers the VLDL level. The major effect of fibrates is to increase triglyceride breakdown, and that leads to their major use clinically, which is among patients who have very high triglyceride levels. These are the go-to drugs for patients with high triglyceride levels. In terms of side effects, fibrates can cause a rise in the liver function test, just like statins can. In addition, patients taking fibrates have a higher risk of developing cholesterol gallstones. That's because these drugs disrupt cholesterol metabolism, and that can alter the cholesterol content of bile. And then fibrates can cause a mild myositis on their own, although this is usually not severe. The main muscle problem that occurs with fibrates is if patients take gemfibrozil, which is a fibrate, together with statins, this can lead to rhabdomyolysis. So in the US, the only two fibrates that are prescribed are gemfibrozil and fenofibrate. And if you give gemfibrozil together with a statin, gemfibrozil inhibits cytochrome P450 enzymes, and this will raise the level of statins in the plasma, and this increases the likelihood of rhabdomyolysis. So because of this interaction with the P450 enzymes, we never give gemfibrozil with a statin, we always give it alone. If you do want to give a fibrate together with a statin, and we sometimes do this, you always use fenofibrate, and that's because fenofibrate doesn't have this interaction with statins the same way that gemfibrozil does. The next type of lipid-lowering drug is the absorption blocker ezetimibe. This is a drug that blocks cholesterol absorption in the intestines, and the buzzword here for step one is that it works at the intestinal brush border. Recall that intestinal epithelial cells have folds in their membrane into microvilli, and this is called the brush border, and this is where this drug has been shown to localize and where it's believed to block dietary cholesterol absorption. It's highly selective for cholesterol. It only blocks cholesterol absorption. It does not affect fat-soluble vitamins and triglycerides. By blocking dietary cholesterol, the result in the liver will be similar to the effect of statins. Liver cells will increase the number of LDL receptors on their surface, and this will result in a modest reduction in the LDL level in the plasma. There's also some reduction in triglycerides and some increase in HDL. The problem with ezetimibe is that it has relatively weak data on hard outcomes. For example, there's relatively limited data showing that it reduces the rate of MI and death. There is some, but not as much as for statins, and therefore this has never been as popular a drug as the statin drugs. Much like the statins, it can also increase LFTs, and another side effect is diarrhea by causing disruption of absorption in the intestine. The next class of drugs are the bile acid resins. These are drugs like cholestyramine and cholestyramine and cholesevelam. These are really historical drugs. They're not used much anymore. They prevent the intestinal reabsorption of bile. So cholesterol is used to synthesize bile, and then bile is secreted into the GI tract, and then it is reabsorbed. These resins lead to more bile excretion in the stool. The bile does not get reabsorbed normally as it should. As a result, the liver converts more cholesterol into bile to make up for the losses, and you get a modest lowering of LDL. The problem is that these drugs are miserable for patients. They lead to bloating in the intestine and bad taste. In addition, patients sometimes malabsorb certain fat-soluble vitamins, and there's an increased risk of cholesterol gallstones. So for all of these reasons, these drugs are hardly ever used anymore. The final therapy for treatment of hyperlipidemia I'll discuss are the omega-3 fatty acids. If you look at the structure at the top of the screen here, this is an example of a fatty acid. One end of the molecule contains a carboxylic acid group, and the rest of the molecule is carbons and hydrogens. We call the carboxylic acid end of the molecule the alpha end, and we call the other end the omega end. If there is a double bond, 3 carbons from the omega end, then that is an omega-3 fatty acid. This is an example of one common omega-3 fatty acid on the screen here. This is icosapentaoic acid. At the bottom of the screen here is another typical omega-3 fatty acid. This is docosahexaenoic acid, or DHA. And both of these are naturally occurring, but they can also be administered as supplements for patients with hyperlipidemia. Omega-3 fatty acids are found in fish oil and in certain types of fish, and consumption of high amounts of omega-3 fatty acids is associated with very low rates of cardiovascular events. Omega-3 fatty acids can be incorporated into cell membranes. They've also been shown to reduce VLDL production by the liver. Their major overall effect is to lower triglycerides by about 25 to 30%, and their main use clinically is among patients who have high levels of triglycerides. They also result in a modest increase in HDL, and there are commercial supplements of omega-3 fatty acids that are available. One of the commonly used ones is called Lovasa. The downside of these supplements is that they have GI side effects like nausea and diarrhea, and some patients complain of a fishy taste in their mouth after they take the supplement. There's one very new class of drugs that can be used to treat hyperlipidemia. These drugs are called PCSK9 inhibitors. There are 2 drugs in this class. One's called alirocumab, the other's called evolocumab, and they were both FDA approved in 2015. PCSK9 degrades LDL receptors on hepatocytes. It binds to the LDL receptor and leads to it being transported to a lysosome where it is degraded. So alirocumab and evolocumab are antibodies that inactivate PCSK9. As a result, there's less LDL receptor degradation, there are more LDL receptors on hepatocytes, and there will be a lowering of the LDL cholesterol level in the plasma. Because these drugs are antibodies, they're administered in an aqueous solution via subcutaneous injection, and this has been a barrier to their use, especially since they compete with statins, which are oral drugs and which are also much less expensive. Their benefit, however, is that they result in a marked reduction in the LDL cholesterol level in the plasma, as high as 60% compared to baseline in some clinical trials. The major adverse effect, no surprise, is a skin reaction at the site of the injection. There's also been some association of these drugs with memory problems. The etiology of memory problems in people on these drugs is not well understood. And that concludes our module on lipid-lowering drugs.